Okay, I'm going to go ahead and get started. We are recording this session, so we also have it projected overhead, so you'll be able to hear questions from the other individuals who are online. I think there were a couple people online. So thank you for joining us this morning, very early. I've got the pumpkin-colored Halloween pumpkin pie colored presentation for you today. I'm going to talk a little bit about human-computer interaction in the context of healthcare. Many of you know that I'm an informatician, so I do all aspects of system design and evaluation in the context of healthcare. I work with patients and with clinicians in designing computer systems in the healthcare context. And so today I'm just going to talk about one aspect of my research, which actually looks at human-computer interaction and user-centered design. This won't advance. There we go. All right. Our overarching goal is to avoid this scenario, and where the computer thinks that the human is an idiot and the human thinks the computer is stupid. Has anybody experienced this? Yes, right. Only one way though. Yeah, you haven't, but the system designers are actually in the back end of this thinking, what the heck's the matter with you peoples? I'm going to quickly show you a little video that is an example of this is part of a study we did in New York looking at neonatal intensive care unit challenges with prescribing. So in this scenario, we've got residents, physicians, nurse practitioners. In this instance, it's a resident. We have a development system, so this isn't a real person. I can hear you on your microphone. Oh, it's. I hadn't hit play yet. Seems to be playing without playing it. Stupid computers, yeah. Hang on. I'm going to shut this one. Give me a second here. Direct 3D. And it won't shut. Give me a sec. Okay, instead we're going to go for this one. So this is an instance of, we did usability testing with clinicians who were doing prescribing, looking at the user interface design and examining where a person was confused by the user interface design. So this is a resident physician trying to do an order. So what do you think of how this computer system looks? It looks complex. It's really busy. It's got lots of choices in it, lots of windows. We've given this physician a specific scenario where they're instructed on which data to enter, and they proceed with making a calculation, which automatically dumps into the computer system here for order entry. Now they're trying to navigate any warnings. So we intentionally created a warning that was making sure that it was going to fire. So you won't always have an instance of the computer system alerting you, but this is an instance of the, he's reading, and so now he's going to go on and submit another order. So how much time do you think he actually spent thinking about what the words actually said? Very little. He's kind of skipping through things, and this is really, really common at the point of care when you have a system that's designed and is very complex. So people become automatic. How many of you have actually driven home or to work and not actually paid, not recognized actually how you got there? Anybody done that? So yeah, this happens in computer systems as well. Just going to go up a little bit here. Just going to make another order. I want to point out that this is a fake patient, so we just called it baby with sepsis new. This is a neonatal intensive care unit context. And so he doesn't even trust the prescription that's in the computer system. He has to go out and double check it and verify it. This is a big problem with your computer system if the automatic dosage isn't trusted by your clinician. So I'm not going to go through this in any more detail. This episode was about a 45-minute interaction with the end user. And what we often do is we give people a series of steps, and we sit back and say, and now what are you doing? And now what are you doing? And this is a think aloud protocol. Then we take these recordings and we code them in detail, looking for a number of different things. And I'm going to talk a little bit about those right now. So today I'm going to talk a very teensy bit about the goals of informatics, a little bit about usability, some stuff about user-centered design, and then I'll give you an example of a user-centered design research study that we have completed the first phase of, and we're seeking money for the next phase. So the overarching vision for clinical informatics is that data should be captured as a byproduct of the care process. So how do we automatically dump those EKG readings into the clinical chart? Or how do we capture information? Ideally, the data would be entered only once, verified if needed, and then reused and reused for data sharing, real-time decision support, administrative reporting, research, and then practice-based evidence. So discovering knowledge from the what the notes have been documented. An example of data collection as a byproduct of the care process is barcoding. And this is a closed loop medication. Has anybody in the room here done closed loop barcoding? Yeah, in which context? And in which setting? In the US, yeah. How'd you like it? I loved it. And so we have lots of good evidence that it can actually reduce a whole bunch of errors. If you look at what happens here, the nurse has the barcode machine. It scans the patient's ID, verifies that it's the right patient. Then the nurse can scan the medications, verify that they're at the right medication for that patient, and tap on, yes, this is a medication I'm giving, so it actually documents the time, it timestamps when the medication is given. And so this is definitely going to be deployed at Vancouver Coastal Health and at Providence Healthcare and at Children's and Women's when they roll out the clinical information system over the next few years. So I want to talk a little bit about usability. So this is a concept. It's the extent to which a product can be used by specific users in a specific context to achieve specific goals. We call this field UX, or the user experience. So we're looking at a whole group of activities. We actually have some experts in human-computer interaction at UBC in many different departments, and what we look at is what's the visual design. We also look at what's the information architecture. So how is the back end of the system structured so that the data that you're either seeing or entering are automatically captured for reuse. So we can reuse it by sharing a screen, so I can see the vitals that have trended over the last several hours or days or months, depending on your context. We want to look at the structure and the management of it. So usually we need people who are managing the databases to keep things well organized. We can look at interaction design, so how do humans interact with computers? One of the things that we can do is eye tracking. So there are people trying to look at using retinal scan for accessing the computer system instead of having to type in your password when you're a clinician working in practice. When might that be a good idea? Yeah. So for infection control reasons, yes. And so what sort of other technology might we want to enable if we've got dirty hands and can't touch the computer? Voice. So speech recognition systems are starting to be deployed in healthcare, and we're looking at how can we effectively automatically capture the data at the point of care. Then we look at usability. I'll talk a little bit more about it. And then this idea about accessibility. There's a whole nother topic area that we call the digital divide. And this is the idea that if someone doesn't have access to the computer system and healthcare is deployed ubiquitously by computer systems, then we may be further alienating individuals who are already marginalized. And so we have to be mindful of that. So there's a whole list of reasons why software fails. If you, they suggest that if you fix something before it's deployed, you will, it costs you $1 per problem. If you fail to fix that problem, it can be $1,000 to $10,000 to $100,000, depending on how complex the problem is, to fix it after you've launched it. So the goal of the whole UX, or user-centered design initiative, is to make sure that we have activities in place to test it with end users before we launch a full product. Then we can capture different things. These are probably usability issues, badly defined system requirements. So system requirements is when we're trying to design something, we look at what are the functions that this system should have, what are the, how should it be designed. Poor communication among customers, developers, and users. Use of immature technology, so launching something before it's actually fully functional. You may be living through that in some instances of products that you're buying. It's actually considered standard practice in some areas, and people are try to do it in healthcare. It's not best practice in healthcare. And then sloppy development practices, so not really figuring out the logic and doing actual testing before you launch something. This has been such a big problem that the Health Information Management Systems Organization has actually launched a healthcare usability maturity model. So if you're in a, the goals are to make the software appear simple. How many of you have an iPhone? Almost everyone. Who's got a BlackBerry yet? Android? Couple Androids. So they, when you first bought your iPhone, how was it compared to that flip phone or that chocolate bar phone you had before? It was like super awesome. 10 stars, 12 stars if you could, and no, except for one individual who hates it, okay? So the idea is the amount of years, they didn't launch the iPhone until 2009. They had the iWatch in production for almost 10 years, and it wasn't launched until last year. So Apple will not launch a product before it's had maximum amount of usability testing. But we're not doing that in healthcare. We want to strive for simplicity. We want to minimize the cognitive load. We want to preserve the context. So in healthcare, that's the knowing who your patient is and where that patient is in their care continuum. We want it to be natural as possible in the context of healthcare. We want consistency. We want forgiveness and free feedback, effective use of language, effective information presentation, efficient interactions. So these are all, as they say, end of the rainbow dreams, and we ain't there yet. But this, the Health Information Management Systems Society has suggested that organizations need to figure out how to have usability actually be part of their deployment and development process. So from the bottom here, a business who's down here, there might be someone who is supporting the need for usability. There might be usability wake-up calls. In healthcare, what does that end up as? If you've got a bad user interface design. Safety, so what might happen? Errors. And then what might happen? Someone dies. Yeah. And we've got evidence of this. If you're not adhering to best practices, we have evidence of deaths due to technology-mediated adverse events. An organization could compile evidence from usability assessments. Up to the very top, include usability in contracts. In healthcare, we're purchasing a contract with a company that provides a software. It's highly unusual for a healthcare organization to build their own electronic health record. And so an organization is fully mature if they make sure that usability is included in the contract. Not always the case. The organizations don't necessarily know the implications. They presume that if a company is selling you something, that all of the safety tick boxes have been checked. It ain't so. So with user-centered design, we want to figure out who the users are. We typically create a persona of the user. So this is like a base case of a person to get a sense of who's the typical person that's going to use this system. We look for common qualities across users. Then we identify this thing called a use case. And this is a scenario in which the person would be using the system. Now, I'm flinging these words at you because it's important for nurses to not sit back and not know some of these words, because what happens, there's a power gradient between the software engineers and the healthcare providers. And if you ask somebody, well, what's the use case? That's their lingo for a scenario in which a person would be using the system. And they'll realize, oh, you have some knowledge about this, and you're going to maybe hold them accountable. I've mentioned why software fails. There's a YouTube video here, and I can post these slides if you want, for looking at a return on investment. The cost of fixing an error after deployment is 10 times more than if fixed before the programming started. Human-computer interaction, it's a discipline concerned with the design, evaluation, and implementation of interactive computing systems for human use with the study of major phenomena surrounding them. This is just a schematic from a special interest group at the Computer-Human Interaction Organization. And the idea here is there's some information processing that goes on in H1. H2, there's language and communication interaction. Then the computer actually needs to be told what to do. Then we can actually evaluate and develop the system so that the human and the computer can talk to each other efficiently. One of the main goals is to simplify a user interface design. So this is a very scanty example, but you've got a laundry list of things over here. What they did was they've inserted a little bar here to chunk things into groups of 4 items. There's evidence that people can only recall between 5 and 9 pieces of information at any given time. And we're thinking actually it's more like 4. So this isn't about multitasking. That's a whole other discipline that people are studying in my field as well. But this is the idea of chunking things into chunks of 4, maximum 4, is going to help the person kind of sort through the information better. I showed you some of those screens on the first, when the resident was ordering the antibiotics, and you saw there were probably 20 things on that screen, not to mention the color's ugly. But we can, the goal is to simplify it. We also use an iterative development process. I'm going to give you, I'll show you an example of how we've used wireframing, which is a process where we have a fake user interface that people can click through. It doesn't deposit any data into a database, so it's easily morphable and fixable. And the goal to use, most organizations that put any money into designing computer systems for their workers have spent a lot of time doing pre-prototyping and getting the understanding of the user experience. We want to make sure we capture functions, not just the design. Has anybody been part of a paper prototyping or computer system development? Yeah, what have you?
I'm working on the project.
Oh, you're on the CST project right now, and they're just using paper prototyping.
No, we're doing it on computer.
With?
And then they're
in the development system?
At the moment we're doing workflow
right.
development for more of the use case scenario.
Right.
And then when we get the certain consultants, we're going to be going in and actually prototyping. I work on the med case for prototyping the different ways that we can use the med in that.
Okay, great. Good, because the thing is that you have to make sure you have actual end users, naive end users using it. Don't just ask yourselves if this is good enough. What often happens in organizations is they do what they call user acceptance. That's their evaluation mechanism, is user acceptance. Instead, you need to be doing end user and expert usability testing throughout the process. So usability testing and expert evaluation could be what we call a cognitive walkthrough. Another method is a heuristic evaluation. So this is taking that persona, walking through a scenario and thinking about what are the violations to usability standards, best practices. I'll show you those in a moment. We can do end-user usability testing with a Think Aloud protocol. So the example of the video that I showed you was a Think Aloud protocol or Talk Aloud protocol. So we gave all the residents and nurse practitioners that were in that study the same scenario, and we designed the system so it would force them to all see the same thing. And what we were able to derive from that was a lot of information about where they were skipping over things and ignoring the alerts. Very, very helpful. This is a list of these things we call usability factors or usability heuristics. So heuristic, the modern definition of it, is a rule of thumb. So these rules of thumb are many of the things that we want our computer systems to actually be achieving. Consistency and standards, visibility of system status. Can anybody think of an example of visibility of system status in a computer system you're using right now? The wheel of death, that's right. But when the wheel stops spinning, it's the wheel of life, right? So yes, you know that, or if you're on a website, sometimes you'll see the little cursor. Expedia, it has the little dots that are going back and forth telling you that it's still alive. That's very commonly now implemented. 10 years ago, it was not the case. You would be on a website, you'd click on something, and you'd be like, did I do anything? Has anything happened there? And maybe they became creative, and instead of showing you that you're still interacting with some sort of a system by showing you something that's moving, they might actually have big font that says, do not click again, right? Thinking, anybody use the RISE system for research ethics here? Yeah, match between system and real world, minimalist design, minimize memory load, informative feedback, flexibility, and efficiency. And you can see these are similar names to those things in the boxes from the Health Information Management System Society. There are about 14 of these right now. Good error message, clear closure. You should know when it's complete. So an example of that is like an online survey that you might do. What do you see at the end that you at the end of a survey, ideally? Yes, thank you. You know, click here to give us your email so you can enter the raffle or whatever it says. So if we have poorly designed systems, a number of things can happen. So here's our software development team from a few years ago, the Pacific Northwest garb and beards. We've got lots of evidence of technology-mediated adverse events. This study was from 2005, published in the Journal of the American Medical Association. Misleading default values. So the default was the lowest dose, not the most common dose. So people would just pick that. You saw how automatic that resident was with clicking through things. It's super easy to make a mistake. New commands in this system, has, the company has been purchased by another company, so this system is retiring. But new commands not checked against previous ones, so people could get 2 orders for the same medication. Poor readability, patient names in small font, names listed alphabetically, names not on all screens. Huge, huge problem. And you'll see that even in existing systems. So you need to make sure that someone's checking for these things. Memory overload, up to 20 screens to see all of the patient's medications. Okay, who designed that? Complicated workflow. The system design conflicted with the hospital workflow. The nurses kept a separate paper record and then entered the information into the computer system at the end of the shift. This is there's a lot of evidence about workarounds. So here's some examples of some safety of electronic prescribing manifestations and rates of system-related errors associated with 2 commercial systems. So this is a relatively recent article, our colleagues in Australia, and you can't read the entire sentence for each of these medications. So you've got metformin up here, and the case of this is hard to read. These things should be in title case. The first word is capitalized. The other words are, the first letter is capitalized. The other letters are lowercase. It's much easier for the eye to read. And the organization of this is just crazy. So you have to use this slider bar across the bottom to actually see everything. And the name of the medication is only at the top. It's not in the sentence. So there's no name of a medication in here. It's really cognitively, the cognitive burden of this is huge. Here's another example where this journal article gives a nice description of how some of these errors occurred. And down here, because of the proximity of sodium chloride and the choice for an epidural route, this person was prescribed to receive a liter of sodium chloride epidurally. Ouch. So they selected the spinal route incorrectly, but no alert came up. Oh, what was around there? Oh, I thought I had another one on the side there. Lots of evidence of nurses not liking the workflow that's imposed on them in using the computer system. So we've got evidence of nurses printing out all of the patient. I showed you the picture of the armband and the barcode scanner. You go to the bedside and then you touch the screen and you automatically collect these data. For various reasons, it either doesn't fit workflow. The machine might beep. What do you do when you're on night shift? It's going to wake up the whole room, right? So lots of reasons why nurses are doing this. They're not doing it just to misbehave. They're doing it because there's something that's not matching their workflow. So they'll print out all of the patient labels, put them on a clipboard, and carry out business as usual. Pull their meds out at the med cart, take them to the room, but they've already done the barcode scanner and the timestamp because they did that at the front desk. So figuring this out is really important. There's a great amount of evidence on this barcode EMR workarounds. Another example, last year in PharmaNet, there were pharmacists were permitted to turn off the alerts. So they had medication, interaction, drug alerts, and the computer, whoever designed PharmaNet, let the pharmacists turn off the alert that there was going to be a serious drug interaction. And so these two men turned off the alert, and it ended up in a lady receiving 2 drugs. She, I think, was immunocompromised, and she was given another medication that it put her at really, really high risk for infection, and she actually died of a serious infection in hospital up in the interior. Now, fascinatingly, the pharmacists were penalized, and so their licenses were suspended for about 3 months. Now, if we're looking at this from a patient safety perspective, instead of being in a blame and shame system, we need to understand where it's a system problem. And I would argue that these people, there should not have been a disable function. And there's some recommendations coming out for different levels of disablement of alerts, and we need to figure that out better in the field. Now I'm going to talk briefly about a user-centered design project that I've been working on with Craig Phillips, and we received some bridge funding. We're calling it Community Quits, and it's for HIV-positive gay men, because men in the Vancouver area, 63 to 71% of HIV-positive gay men smoke cigarettes. And this is a huge deviation from the Canadian average of 20%. We know that smoking is a major modifiable determinant of health and must be addressed in this population. There's actually some evidence coming out that HIV-positive people who smoke have worse health outcomes. So it actually affects their immune system. Not surprising. So we've been looking at designing a smoking cessation tool that's specifically targeted to HIV-positive gay men. it hasn't, these haven't been designed yet. So we were wanting to look at the culture of smoking and design a user-centered web-based tool for smoking cessation. We conducted 2 sessions of participatory design. First one was to identify personas, and we had 2 4 or 5 hour day-long workshops to identify personas, and I'm going to show you what we did with that. And then we had a total of 7 days of participatory design for requirement specification. So what we, first thing we did was a thing called affinity mapping. So we asked people to sit at a table and write down the things about smoking that they can think of. So write one thing on a Post-it note. Then silently, and again, these were groups of 7, 6 or 7, silently they had to go to the sticky board and organize them. They weren't allowed to speak. So we were using a process called game storming, where we were trying to make it a playful environment so that it sets aside your business head. So instead, we're making it playful. That theoretically allows for more creativity, and it prevents people from second guessing what their right answer should be. We then held a round robin in the group to ask for priorities for the affinity mapping. And we, the main category so this is thinking about what information would you put on a website and how would you prioritize it. So the main categories were reasons to stop smoking, including health, financial, and relationships. We then did something called empathy mapping. And this is a game where we had smaller groups of people, 3 or 4 people. So each of the groups created 2 empathy maps. And we used these to identify the typical HIV positive gay guy who would be using a smoking cessation software. We let the groups, we walked around and kind of coached them into how to do it. And one of the groups came up with this character called Riley Homo, and we have different characteristics of him. We use this empathy mapping here for most of them. We ask them, what do you think and feel? What do you hear? What do you say and do? And what do you see? So with all those, and then in the center are the characteristics of the person. We also asked them to then kind of go into the website design. We had them do this pain and gain activity, and we then summarized all the think and hear and see and say. We then created some personas. So this is a persona. This is the character that you would give to your designer that is the typical person who would be using this system. So each of the groups named their persona. The first one was called Biff Barista. He's a 49-year-old man, has been considering stopping smoking, works as a barista in the downtown core of a major city, dreams of other jobs. Smoking is ingrained in his daily routines, and he finds many of his everyday tasks trigger his urge to smoke. Likes to smoke when he wakes up, during morning coffee, while he prepares for work, during breaks at work, when he leaves work, after dinner, after sex, when feeding his pets, when drinking, before going to bed, as well as any time something unexpected or distressing happens. I'd say this person's addiction scale might be kind of high. His craving pattern may seem like that of any smoker. However, he's not an ordinary smoker because he's living with HIV and is a gay man. I'm not going to go into detail on the others, but they were all quite similar. We actually did a persona validation episode in our second visit with the group, and one of the younger guys was kind of angry that all these are 50-year-olds. So we've created a new persona that's a 25-year-old. This is our participatory design. What it looks like. It's a big mess, and you have to be able to manage that kind of chaos if you're going to do this kind of work. We then, in our second phase of participatory designs, we had a larger group of people. For both of the sessions, we create a safe space dialogue, and then we have a parking lot. Stuff people might want to mention, but we don't want them to kind of go down that path and really hijack the conversation. So we have a parking lot. In the safe space, we say, it's like Vegas in this room. So you guys might know each other from your community activities, but everything that's in this room stays in this room. Of course, we have consent when we're, before anybody participates in this. One person talking at a time. We want to laugh with people. So we create this safe space agenda with the community at the very outbreak of this starting. It's excellent. It's super, super, it helps you manage a big group, especially this group. We had 13 people in it, and it was sometimes there would be some challenging behavior, so we could bring it back to one person talking at a time. Please laugh with people, not at people, that kind of thing. We did an activity called Product Pinocchio, and we asked people to give us the characteristics of this software. So they came up with, they actually named him. His name is Peer Support, because he's going to be a peer support tool. You can see how optimistic he's got some sort of a voice they want. He's resourceful. He's bilingual. We did have bilingual participants in our bilingual with multilingual aspirations. He's charismatic and knowledgeable. He's international, cultured, and altruistic. He's happy, non-judgmental, humorous, ageless, and adaptable. So these are all very aspirational. And when you're actually working with a designer, these are the kind of words that you want to kind of anchor around, how am I going to design this thing? We then did a value mapping activity, and we used a number of different challenging scenarios and what were the values that were enacted in those. And we came up with a list of these characteristics: pragmatic, equitable, caring, concern, compassion. And then we found out what's the community. We also, this is Charlene Ronquillos, who's a PhD student here and who was working with us as a research assistant on this. We used a wireframing software, and Charlene created a fake website, just the front end of it, using a software product called Axure. We had all of the guys, and I don't have a photo of them, but there were 13 guys, with some with iPhones, some with iPads, some with laptops, who were all clicking as she was designing. It was mayhem, but really exciting. They felt so engaged, and they felt like we designed this. I'm going to quickly show you the product. I'm just going to show you the screenshots of it then. So we created this peer support, and it's a clickable site, and the guys in our project were clicking through it, and we didn't have quite enough time in our study, and for our next study we'll plan much more time, where we had them clicking through and providing feedback in the morning. Then we spent a couple of hours, redesigned it, and worked through doing kind of some impromptu usability testing in the afternoon. So here's an example of one of the participants in this smoking cessation network that we're designing, and we have Biff Barista. So here's our persona coming through to the fake example of the website, so that we can get the maximal participation in the design process. That's all I have to say for this morning. I'm going to, has anybody seen this example, this cover of the Canadian Nurse? Yeah, what'd you think about it? She looks, yeah. So my goal in life is to help design systems that are going to be usable for clinicians and for patients so that we don't have this frustration and anxiety in and bringing the clinician into the design process. It's crucial, and we have to figure out how to do it better. Thank you. Any questions?
So, like my experience with the system was like they gave it to us at the end, and then even though they had nurses on the actual development side. So throughout the process, do you guys use or get nurses feedback on the different steps so that you like actually get the feedback from real people who would be using it?
So business best practice for software design. Did you guys online hear the question? I'm presuming you did because the audio looked like it was pretty good there. So the business best practice is you would never launch something without getting end user feedback early on. What's happened in software design, the whole process has matured over time, and people have thought that, well, those are end users, they're not experts, and I'm the expert. So there's a power dynamic. What some groups are trying to push the agenda for involving end users in using like a wireframe or something that's clickable through very early on, before all of the hardcore programming is done. We're a little bit about using the development site without doing prototyping before that, because you could actually take screenshots of the system, shove it into one of these wireframe things, and drag stuff around and drop it around. The other stuff, you're relying on the development team who are the software programmers, to design what you tell them from probably a paper prototype, hopefully at least paper, and not just something verbal. So I'm working with PHSA right now to try and help them think about doing wireframing earlier on. I've talked to the CST leads to kind of give them a little bit of this talk, but they, I don't know if that machine can be steered away from the traditional software development process in an organization. Yes, Wendy.
So I ended up working with a PhD student with an engineering software guy who worked with software design for years, and he was using Agile.
Yep.
But he came up with this grounded theory that talks about reconciling perspectives. And what happens with software developers when they're not entirely clear that they're having good communication with the client. And talked about things like bunkering, where they lock themselves in rooms and try to keep everybody away. Has anybody actually looked at what's happening more on the software development side with the user or purchaser interface?
Absolutely. So, I mean, that's the team that usually needs to have some organizational leadership to facilitate that communication and building that trust. But that bunkering is classic. It's an us and them thing. So when you see the literature that's coming out about organizational leadership and software design in healthcare is suggesting that the leader can bring those the geeks and the clinicians together and get a respectful and actually working together towards something. Part of that can be overcome when you have clinicians who have some formal training in clinical informatics. So they know the language, right? They know what a use case is. They're not looking like a deer in the headlights when the software engineer says something. So the software engineer feels like they're responsible for all of that. So there is best practice, and if you were at the leadership talk last week, Betty De Silva talked about how she's trying to help her development team at PHSA actually adhere to best practice in software design, because it hasn't been invoked fully in healthcare, and we need to get there. Fuchsia.
I just had a quick question about how about costs and how does that play into, number one, on the EHR sort of side of things? How do organizations go about costing these things out, and then how does that end up being an inhibitor to actually putting things into practice? And then on the other side, in terms of designing interventions for specific groups, what's it cost to design, for example, the website on smoking? What's the investment that you need to put in that front?
Well, it depends, and if you were doing this as actually a product that is going to be marketable as something that people are going to purchase, that's one thing. The return on investment is a big challenge. I don't think we know the answer fully right now, but if you're going to design something, you're going to probably need at least a couple $100,000 to have a proper design team and to properly be figuring out the interventions. So in the context of the healthcare system, so the companies that have products will be, they have a ticket on it, and then the organization needs to figure out how to maximize the team to build that. So I know the price tag here is around 50 million, but that's actually pretty cheap considering when I was in New York, it was 50 million for 2 hospitals that I was at. And this is for 20-something hospitals, right? Yeah. But the key thing is that you do not need as many geeks as you think you do. You need clinical informatics specialists who can do this pre-work early on, and they are clinicians who may have a little nudging around software design, so you can avoid some of the biggest pitfalls of deploying something that is poorly designed, and you can actually save money in the long run. So there's a class coming in here next. Thank you, everybody.
Thanks, Leanne.